Hello and welcome to my yet another session of Asset Talks here. Today we are very lucky to have a very prominent speaker here, Professor Dr. Nachiket Moore, and I request Professor Vidita Vaidya to give us the introduction to his.
So it gives me a great pleasure to have Dr. Nachiket Moore here with us to give this asset colloquium. He's an Indian economist and researcher and has worked in areas of financial inclusion. But today he's going to tell us about his work in the mental health policy space. He comes from a farming family in Yavatmal, and then he did his bachelor's in physics. So there are physicists in the audience, and this is another different trajectory that a physicist could take. From there, he went to IIM Ahmedabad, where he has an MBA and then a PhD in economics from the University of Pennsylvania at the Wharton School, where he studied finance and economics. Over the past 2 decades, he worked at the ICICI Bank, where he pioneered rural financial solutions, led the ICICI Foundation for Inclusive Growth. He served as a board member for the RBI from 2013 to 2018. And he's been a member of the Planning Commission for High-Level Expert Group on Universal Health Care, the Primary Care Task Force of the Ministry of Health and Family Welfare, and also the Health Commission for the state of Himachal Pradesh. He's currently a visiting scientist at the Banyan Academy of Leadership in Mental Health and a visiting professor at the Indian School of Business in Health Systems Design. His most recent research focuses on innovative mental health system designs, emphasizing how community-based care, digital interventions, and equitable access can change the landscape of available mental health services, but also shape India's mental health landscape. And with that, I'm just going to invite Dr. Nachiket Moore. Thank you so much for accepting our invitation. And I'll also ask people to keep questions till the end of the talk so that then we will be able to answer them.
Thank you, Dr. Vidita.
Yeah, big thank you for giving something.
Oh,
It's the TFR art book.
wow, what a gift. Wonderful. Thank you so much. Normally, of course, I get this after I give the lecture. If it doesn't go well, I see them hiding it under the table. So I'm glad I got it early because now it doesn't matter. So thank you all for inviting me to be here. I'm not a scientist like all of you. I had a lovely opportunity to spend the afternoon with the students of Dr. Vidita and her lab. And I learned a great deal from it. This work is much more applied. The work really began more out of a sense, and unfortunately in India, this comes for many diseases. We are a large country, and sadly, we are a very poor country. Our per capita income is $2,500, distributed very unequally. 10% of the population, people like us, live lives of Scandinavians. 90% of our population live like the Sudanese, amongst the poorest people in the world. We don't have enough doctors, we don't have enough nurses, you name the parameter, we don't have enough of. And the frightening thing is we are not likely to have enough of over the next several decades as well. Right? So the challenge is, so therefore what does it mean? Can we solve these problems, or are we stuck with them forever and in a fatalistic, Indian kind of way, we just watch and see what happens to this without necessarily being able to solve it. So this is really where we began our journey to try and understand it. And we were looking for pathways, thank you. We were looking for pathways that were evidence-based and ideally stuff that could go directly into the policy realm, rather than go then through another 30-year cycle of research and trying to figure things out. Right? So that was kind of the motivation. Just to give you a sense of the numbers, India, everything is big, but unfortunately, mental health is no exception. The estimate, again, you might say, what is the real data underneath this? That itself is a problem. We don't really have a proper surveillance network. The only real data we have, if you call it real data, is suicide data, because until recently, suicide was a crime, and therefore the police recorded it. So you can go to the National Crime Database, which is a reasonably accurately kept database, to see what the suicide statistics are. Everything else is estimated based on surveys, on different things that are done. But I would say 200 million seems like a number that most people seem to agree makes sense. Likely to rise, you might say, why will it rise? Why will not globally? This number seems to be stabilizing. Why is it going to rise? In India, urbanization is ahead of us, for example. We are going to build thousands of new cities, right? And cities on some aspects are protective. Crowding, for example, is protective against some issues. Suicide is somewhat protective. Depression is somewhat protective. But schizophrenia, for example, is pathogenic. You get a lot more anxiety. You get a lot more triggering of diseases. So our modeling and WHO data shows that you will see an increase. Unfortunately, our strategy, what we found, is overly recovery focused. If you look at what the large national institutions are doing in mental health, what the psychiatrists are doing, what you're seeing in the mental health policy, it's all recovery focused. And in fact, recovery with psychiatrists, or maybe psychologists in some cases, but largely driven by psychiatrists. We just don't have the numbers. What we find in our work is that 80% of people, actually the numbers people tell us is 95%, are not able to access the treatment that they need. And if we followed the classical treatment model, this is true unfortunately of most diseases, but certainly for mental health, we would need 500,000, 5 lakh psychiatrists. We have 10,000. Right? So there's no way we are going to make this number up over even the next 3-4 decades. Right? So that whole strategy for us is a non-starter. We have only 2 choices: live with it and suffer in silence, or find some other pathway. And that's really where this work is. And the sense we were left with at the end of it, just to give you a little preview of that, actually there's a lot of room for optimism, a lot of room for what can be done. Some of it informed by the work all of you are doing, some of it is just informed by global data. You can see a lot more. So that was our objective, population level strategy. This number, this 2443 to 600, there's a metric, I don't know how many of you are interested in that. It's called the disability adjusted life years. We know life expectancy, which counts mortality. But for a lot of diseases like the ones that we are talking about today, death unfortunately is not necessarily the release that one gets. You live with the disease. How do you count that? So there is a whole lot of machinery that was created some decades ago by the WHO. And then gradually, Gates Foundation funded a large effort called the Institute of Health Metrics at the University of Washington. They bring out this data. It's called disability adjusted life years. And then there is the DALY rate, which is per 100,000 population. Just to give you a sense of what these rates look like, aggregate across all diseases, the worst numbers, countries like Democratic Republic of Congo, South Sudan, you see 85,000 life years lost per 100,000 population, right? India is at 35,000, give or take. The best you see, in fact, it turns out the Middle East actually has done quite well. Despite all the stresses and strains they're experiencing, are numbers close to 10,000, 15,000. So that's kind of the range within which you see this number. About 10% of the DALY burden is accounted for by mental health in most countries. Some places you see a bit more, some places you see a bit less. In fact, if you see, like, our number is a little bit lower than the 10%, it suggests undercounting rather than a lower disease burden. It could be a combination of the two. Maybe because if we are much more agrarian, much more rural, the joint family is still very intact. It may be that actually people are more protected than we had imagined. And that if we do have a large numerical burden, it is anxiety and depression that is a lot of it, not schizophrenia and bipolar disorder, which is why you'll see the big numerical number, big prevalence rates, but you'll see low DALY rates because these are diseases that don't have the DALY equivalent. And of course, our paper, as all strategy papers meant to inspire, mental health burden of India, pathway to zero burden. Somebody asked us, are you crazy? Where is the zero burden? But I told them, then what is the target? We should put 10%, because there's no other target you can have. Either it's zero or no change, 100 or zero, right? So we said, well, zero looks more attractive. So it's kind of a pathway. We think we have some ideas to take it to 600, which itself we think is a tremendous achievement if we can do it. we do have some ideas we have left over from 600 to 0 as the way forward. Where are the opportunities for us, right? What are the ways in which, and that's when I met Dr. Vidita for the first time. I had read of her work, and then I reached out to her because some of what we were saying and what we were seeing in the evidence base looked like what she was saying from her research and from her background. And I was, very grateful that she took the time to speak at one of my classes where I teach a course in public mental health, and then we recorded that. So we now, with her permission, if we are not able to get her, we use the recording, because in some ways it makes the point very powerfully of what is the origin and what are the stories that, mechanisms that we can tell for getting us there. 50% of the burden is visible by the age of 14, 75% by the age of 21, which really gives us a nice population, school and college, home, school and college, where we can work. These are accessible populations, that we can actually reach out to. The only issue is, if you are worried about disease burden in 2040 or 2050, these children are being born now. You have to act today. You can't say, I will do research for 15 years and then I will start, because then this cohort you have lost. Then you'll have to start afresh with a cohort later on, right? Which is why the evidence base becomes quite important. The issue of prefrontal cortex, again, our understanding, partly informed by Dr. Vidita, is that there is an opportunity. It grows slowly. It is therefore can be subjected to insult and injury over that period, but also opportunity for repair and to work with it for much longer. There's also some evidence of continued plasticity at much older ages. And I'll present to you some evidence that we were able to find that was quite interesting for us to see. And then there are strong genetic predictors. Now you might say, what do you do with that? Belief is, there are multiple things you can do. Once you know a population, and I'll spend some time on it, that is at risk, you can target care early. You can look for opportunities for prevention if possible. Again, there's controversy there. Can you prevent schizophrenia or not? Some empirical evidence suggests that you could do it, but the mechanism of how this happens is not, at least to me, not totally transparent. But certainly early treatment, because unfortunately, and that's the other tragedy of mental health work, the medicines that we use, we don't have too many. A lot of the medicines were discovered, I wouldn't even say invented, even by chance, accidentally. And a lot of the medicines are 30, 40, 50 years old. We don't really have new molecules, new medicines. We don't even understand the mechanisms of action. We know you take this, this happens. Why it happens, not totally clear. In fact, for those of you that study mental health or this DSM stuff, right? Originally at the time of Freud and such like, there was a belief stress is the underlying issue. You are really, but that's all didn't work. So the DSM people gave up entirely and started to just describe symptoms and give it names. The evolutionary tree of mental illness has been abandoned for a while because we have no idea what is linked to that. There may be two diseases that have very different symptoms. In the DSM, they'll be called by different names. They may have a common origin, but we have no idea what that origin is. So, unfortunately, that's the reality, which is why early action becomes quite important, because if you want to optimize the benefit of the drug, you must act as quickly as possible. So we came up with somewhat happenstance that it all turns out to be 4 Rs, though it doesn't quite rhyme well, but one thing you will discover in the policy space, those of you that are interested in, is a big performative element in policy. Otherwise it becomes hard to get. You're all listening to me attentive because you're all scientists. By now, if I had not held your attention, people looking at their phone, people will be, somebody will be stepping out. The policy audience has got the attention span of a child. So you've got to make sure that you keep it excited and interested, which is why mnemonics like this are quite helpful. But it accidentally came up that way. So we looked at 4 potential dimensions. I will spend time on it a little bit later so that you have a sense on each one as to what do they mean. So those are the dimensions in which we want to act. But the issue is, what are the actual tools we have to act on? So these are the somewhat generic tools in some ways, genetic domains, social determinants, Education is something you know already, community you know already, built environment is another important social determinant, economic certainty, uncertainty, another social determinant. The good thing is they are broad, they are population level, and as I will try to convince you, easier to act on. I can change things at a policy level. For example, we know in tuberculosis, we need enough separation between buildings in order for air and light to come through, right? The Slum Rehabilitation Act has diluted that. So you go to Sivri, you go to some of these places, you'll see these narrow corridor buildings, high TB burden. You see, the Bombay Development Department chawls they are designed with what is called a 63.5 degree light rule, right? No TB. They've got many other problems, but they don't have TB because they have the separation. All I need to do in order to convince somebody to get the occupancy certificate changed, and reintroduce the 63.5 degree light rule. And over time, all buildings will start to show the separation that I need, right? So I can get the benefit at a population level with not, person by person convincing. Public health, you have a sense of what that is, primary care, hospital care. Long-term care is more diseases like schizophrenia, bipolar disorder that are chronic diseases. But they also have other elements which are kind of socially determined. Like, for example, if you go to many mental hospitals today, one of the tragic realities will confront you is full of women. Why? Because the men have been taken back home. The prevalence is not high amongst women, is my understanding. It's just that our society takes the men back home. Women, unfortunately, are somewhat left behind. Many of them are actually not sick. I did a project on looking at some of these mental hospitals for a trust, and it's really quite shocking to see what is the numbers that you find out. So then you have to think about long-term care. What do you do for these men and women, but largely women who are left behind? How do you give them a longer-term, meaningful life that both aids in their recovery, continued recovery, but also they're human beings. They want to live a life that is as fulfilling as possible, and they're not necessarily sick anymore in the traditional sense of the word. There are, we use this phrase called venues, which are again places where the action will take place. The school is an extremely important venue. The daycare center is an important venue. What is happening at the home is very important. Of course, communities and workplaces are important as well. So resilience is, in the classic sense, the way we define it, is the ability to withstand the shocks that you will encounter through your life and be able to address them through internal mechanisms rather than developing mental health complications that you have. These stresses and strains may be environmental, may be family oriented, maybe insults and injury that you experience. Your dating life is not going well, your college life is not going well. There are many things that are going on. So resilience is an important component of what we thought would be important. And since this was a somewhat science-based audience, I thought, let me just focus on what are the mechanisms we thought are mechanisms that we can activate, right? Some of it will be familiar to you as researchers. Early stimulation and nurturing, there is strong evidence. There's this very nice project that was done by Gertl. It's called the Jamaican Early Stimulation Project, in which in the 60s, simple interventions, colorful toys that are given to child, because in a poor person's home, the home environment is brown and gray. There's no color, right? If you give color, there is a sense that the brain experiences a level of activation that it doesn't with browns, which is why you get these little mobiles, the plastic mobiles that go up and down. They actually just create a colorful environment for the child. And more complex interventions as well, not just that, and nurturing. So we find strong evidence of these things being done early on long-term life. The Jamaican project, for example, showed 40 years later, it was a properly done randomized control trial, a 40% difference in income between those that had received the stimulation those that had not. It had persisted over an extremely long term with this relatively simple 6-month intervention that you saw. Another area where we see a lot of evidence is behavior self-regulation. Now, I don't understand the brain mechanics as well, but my understanding is that the hippocampus, prefrontal cortex, amygdala, that axis is strengthened through a variety of mechanisms that allows you to then sustain this behavior. And some of the interventions that we speak about that we found in this category, again, what you find is quick interventions, maybe a year, maybe 2 years inside schools. We have rolled this out now in multiple locations in India. The teachers are not even told this is a mental health intervention. One intervention is called the good behavior game. They think of it as it'll help me manage my classroom better now. But the impact on aggressive boys, the girls' impact is somewhat attenuated, but on boys, 25 years later, you see a sharp decrease in aggressive behavior, suicide, violence, depression, big numbers and sustained numbers that are there. Importance of non-cognitive skills. Again, there's this whole issue of is the schooling system as designed today overly focused on cognitive skills? The math, the language, this, that, and the other. One of the things that I'm keen to understand is, did the COVID years strengthen non-cognitive skills? Because children played, they didn't go to school, they were not bored out of their skulls by somebody telling them 2 into 2 is something, they actually played, they participated in things that one might be doing. As you know, one of the best school systems in the world is that in Finland. Until the age of 11, you find children are really not being as engaged in cognitive activities or cognitive training as you might find some of our children in country. And then, of course, there is good evidence of old age stimulation. There is, it's called the Experience Core, is a project that we found run by the American Association of Retired Persons, AARP. What they found is that if you engage older citizens in cognitively challenging tasks, it can't be that you simply looked after your grandson and he's playing somewhere. That's not enough. You must teach math. You must teach language. You must get into it, right? They found measurable differences on scans in the prefrontal cortex, suggesting that even at that late stage, which is people like me, there is some hope that you can actually reverse some of this, at least the pace at which, I think the decline, my understanding is continues. It's the rate at which it declines, changes, quite a bit. Another area that we found, while resilience is helping you deal with stress, there are some types of stress that in some ways we need to work at eliminating. And one of the questions that I was trying to answer here is why? Why should that have an impact on mental health? And what is the evidence that it actually does have an impact? I saw today that the paper that I'm familiar with is a paper that some of you are working with as well, the Feasibility paper on the adverse childhood experiences. Clearly a paper that has found a lot of resonance in our work because we find that that stress seems to have a long-term impact. Now, what are the pathways? I learned something quite interesting today as to what may be some of the mechanisms by which this impact is there. This paper itself has a somewhat empirical feel to it. I don't get into the mechanisms as much. We don't get into that. We just tell you this is what the evidence shows. And the good thing is the evidence is 30-year longitudinal evidence. It's not, like 2-month RCTs. So you can be somewhat confident that these are sustained outcome benefits. Bullying is another pathogenic stress that we think should be eliminated from school, college environments and perhaps home environment, but certainly from school, college environments. And the good thing is in all of these, we were able to find very strong programs that have evidence base that stretches over decades that tells us what to do. And again, that gave us some interest. Lead and paint, intellectual disability, it turns out some half of it seems to be accounted for by this one pathogen that is there in the, unfortunately, not just in paint, but in so many other things that we are consuming, including haldi, I'm told, has now, a fair amount of lead in it because it gives it the color that people like so much. And exposure to violence, again, not just ACEs, but even later on in life, that seems to have a long-term impact. These are the two, resilience and stress reduction are the two mechanisms that we have, and all of our interventions will fit into one or the other or both. The question now is, how do we target this stuff? How do we do anything about it? Right? There are certainly some areas in which you can recognize risk early so that you can act in a somewhat concerted way early. Genetic risks, I don't have to tell you all, about this. We know, for example, schizophrenia is a 1 in 8 chance if you have a first order relative that you will get it. And you might say, therefore what? It can certainly be used, as we are seeing in sickle cell anemia work, to stigmatize populations, to say, oh, this is a problem. Or in a beneficial system, it can be used to target early intervention. There is some belief that one can maybe even prevent the transition. You don't see schizophrenics at 13. You see them at 15 or 16. There is a certain, puberty is an important driver. I'm told viral infection could be an important driver of converting from one to the other. I'm not a scientist. I'm not even a psychiatrist. I'm just relating to you what the evidence seems to suggest. Bipolar disorder, again, high genetic inheritance capability, something one can do. Occupational risks, right? There are interesting occupations in which, I was called in for a whole afternoon session with an institute in Hyderabad for the armed forces, joined all 3 armed forces. That's an occupation that produces unusual exposure to all kinds of outcomes. And they are quite anxious about what they are to do. And not just, as it turns out, on the army person, but to their spouse, on their children. Right? So this kind of a second order, third order effect that you start to see now once you become conscious. But it's not just the army, right? I don't know how many of you have called a call center of a bank or something else. You're not calling them to say what a wonderful bank you are. You're calling them because you're really upset about something or the other. Now remember, who's the person on the other side? It's a young person who has 0 power. She or he is at the lowest rung in the totem pole, but they are getting the full hit. My own thought, and this is what we are recommending to workplaces, is the psychiatric first aid that is being administered as a part of the battle mind program of the US Army is directly translatable to the stewardesses in Indigo Airlines, to ground staff in most airlines, to BPO staff. These are all people being subjected to battle-like conditions, experiencing great deal of trauma. And is it possible to, if you recognize that early, you can start to act early across populations without waiting for them to figure out what to do. And clearly, exposure to ACEs, if you start to discover children, adults that have been exposed, prison families, divorced families, some of the markers. Without going into a detail, one has a quick sense that there could be an ACE exposure here that we need to be conscious about. How do you enable recovery at scale? One of the questions that comes up is, okay, fine, you do all of this. There will be some people that will be left behind. With 10,000 psychiatrists, what is your plan, right? And that's something we have struggled with. What is the idea? The evidence is starting slowly to accumulate that there are actually pathways that are possible, right? Self-care is an opportunity that allows you a lot more stuff. We have given examples of, for example, there's a set of videos that the Oxford NHS produces on PTSD, on psychosis, on, A, to understand it better, B, to treat yourself a little bit better. Now, there is an alternative thought process that people have had, which we have not mentioned in our work, but has a lot of appeal, is lay counselors. Can you work with people who have limited training? Can they go out there? Unfortunately, we were not able to dismiss evidence of harm from a poorly trained lay counselor, right? And, for example, and sometimes the logical, obvious answer is the wrong answer. So, for example, when people say you've gone through a trauma, talk it out, right? It turns out that the RCT evidence shows that the brain was trying to repair itself. By talking it out to somebody who's not trained, you made it worse, because now you're actively hurting. I don't know how many of you have had post-purchase regret, right? You buy something, you come home and say, oh, what was wrong with me? 1 week later, you ask yourself the same question. You feel, oh, wow, it was such a good thing. Because the brain has repaired itself and has said, I will reduce cognitive dissonance. Most of us have a rosy memory of our childhood. It wasn't actually that great, but the brain has processed out a lot of the rough stuff. And by talking about it, so again, you have to be sure that the counselor that you're encountering is actually well-trained. And then if you say, I will have well-trained lay counselors, then we come back to the problem of why can I not increase the number of psychiatrists? Because if the problem is I don't have training capacity, which is the real issue. So in some ways, we went away from that approach. We felt much more careful, videos, self-care. We've not even right now put digital tech. There's a lot of possibility there. Right? We now are starting to understand things about gaming that we did not understand earlier. Earlier, the data showed direct dose response. More gaming. In fact, in my public health course, I show a graph in which you find that for women, every hour of additional gaming produces increased suicide risk. For boys, it's inflection at 3 hours. Up to 3 hours is no increase. Now we are starting to see that maybe we understood the direction of causality wrong. Actually, maybe it was working in the opposite way. And because you started to cut people off, there's a very nice Lancet review in the Lancet Adolescent and Child recent, it's a comment, editorial, that actually turns the whole thing upside down. It seems to suggest that these were beneficial tools with low risk of harm. People who had a high risk of harm inherently benefited from it, but because you cut off access, they actually got hurt more. And that really what we should be doing is understanding there is a subgroup within there that has an addictive personality that we need to find and do something about. So we were conscious of this, but we didn't actually get into the direct program. Question is, next step, what do you do? Well, there are programs coming up in the country now and worldwide that you see, which is the health worker type program, but I'm calling it a behavioral health aid. This is not a quick training program. It's about 6 months. It is not the 7 years of psychiatry. There is evidence that if you train, it's not a lay person anymore. This is an actually trained behavioral health aid that knows what to do. More importantly, knows what not to do. I'm working with the Banyan. They have their own program, which is certified by the University of Madras, to build a national behavioral health aid certification process that allows us to have, we need at scale about 100,000 of these people across the country that can actually do this work in a sensible manner. They will not be your first point of contact. First point of contact will be self-care, will be the lay health worker that you meet, who will then refer you to the behavioral health aid, who can do a little bit more. And then what the Nepalese have done and other countries have done, Brazil has done, is built out a collaborative care model in which now once you've gotten to the behavioral health aid, you actually don't see anybody else. You only work with the behavioral health aid. She will consult or he will consult with a psychiatrist or a psychiatric social worker as needed in order to direct your treatment. In the rarest of rare cases, you might directly interact with the psychiatrist, but if you build protocol, if you build clarity of what to do, you can manage this with. Nepal has not even 10,000. It's, I'm told, 1/100th of our number is that their total number of psychiatrists. But yet they've been able to build a strategy that, at least aspires to cover the entire country, in which the direct engagement is somewhat limited. And long-term rehabilitation, the Banyan, which is where I'm a volunteer, we have developed, WHO recognized this program, it's called the Home Again program, where collaborating with rural communities, collaborating with not just rural. For example, I met mall operators, right, in Tejpur. They want to employ women who have recovered from long-term mental illness. Why? I asked the mall owner, sir, I'm very pleased to hear that. But why exactly do you want? He said, see, my tasks are repetitive. My tasks, a person trying to build a career to take my job at some date is not likely to want to do this job well. Your people thrive in this environment. They want regularity, they want structure, they want smoothness. This is exactly what I want. So he told me, sir, you have more people, you give me, I'll take everybody. So there are places where one can build halfway houses. So these women that are working in these malls, they come together, rent a larger space. They need continuing medical attention. It's not schizophrenia is not a disease in which you can, so you will need the behavioral health aid to be engaged with you over your lifetime, to check on you, to make sure that you're not regressing. And everybody has different, Banyan has some people who need to be taken back into institutional care because not everybody necessarily progresses in the same way. But the combination of these four things seem to suggest that we can actually mount an effective treatment strategy as well without being caught up in our limitations. What did we do? We basically went to a very comprehensive global search for evidence that must at least be 30, 40 years. It can't be short-term evidence because there are programs. For example, there's a program that we saw called the Perry's preschool program. That initial hypothesis was that if the brain is plastic at an early age, why can't I change IQ? Right? So that's what the intervention was. It was designed to work with very young children to accelerate IQ development amongst lower IQ people. First 3 years, I'm told they saw sharp jumps in IQ, but it attenuated. By the 10th year, there was no difference between control and intervention. IQ had gone back to whatever it was that was originally estimated to be. The control was not that different from intervention. But it turned out that the intervention group had developed a whole lot of other resilience capabilities that had a powerful impact on mental illness or mental wellness of those individuals. And that sustained over the next 20 years. So they didn't quite get the intended impact. Now, we want to pick up some of this stuff in the work that we did, which is why you do have some interventions that have a shorter evidence base, but most have this character. I mentioned to you earlier, evidence of harm we wanted to look at very carefully. I was sharing with some of you earlier today, one of the challenges with mental health is that it's regarded as a social intervention. Because there's no drug involved, you regard this as something that you do, so you track averages. But unfortunately, the dispersion, the higher moments, you have to worry about. People are starting to discover that, for example, if you are a depressive personality, you will have more rumination. You will sit in a corner and brood a lot more. Now imagine if such a child is now told, do mindfulness meditation for an hour. They're going to brood even more. And schools started to find that these children, after the mindfulness meditation session, went out and took their own lives. Because now it had come to a point with the 1 hour of just artificially sitting still, that things had gotten they couldn't deal with it. Right? Social emotional learning programs, where people are sitting in there and doing sharing and caring and, this is my problem, the stigma attached to it, all kinds of other problems that associated with it, where people had to disclose their sexual identity, they had to disclose all kinds of stuff, right? And then again, the trainer's ability to handle this well. Maybe in the hands of a well-equipped trainer, this works well. In the hand of a busy teacher, sometimes it works well, sometimes it hurts. And more about evidence of harm. So many of these interventions are not mentioned in our paper, though I will not tell you that they're all without merit. It's just that we felt maybe we're not ready for them. And then we had this phase 1, phase 2. Phase 1 are more direct, immediate interventions. Phase 2 So give you a sense, what the phase 2 intervention is. That's with the 600 to 0. These are interventions which need a level of change in policy, like universal housing. We know that you don't have a steady home to live in. The links to mental illness are quite profound. But to guarantee everybody housing needs a level of engagement at policy level that we think will need deeper conversations, which you can't start operating tomorrow. So we put some of these interventions in the phase 2 category. We built a simulation model because obviously, journals want to know, okay, so what is the actual implication of this? And please read the paper, you'll get a sense. Finance, one of the questions that people want to know is, can we afford this stuff? It is all very well to talk about these great ideas, but where is the money? For example, people have developed wonderful X-ray machines that I can put into primary care settings. I'm excited when I see them. I'm deeply unhappy when I see the price, 25 lakh rupees. How many primary care facilities? We need 350,000 primary care facilities to have X-ray machines. I don't have the budget. The country doesn't have the budget to put 25 lakh rupees. What is interesting here is combination of our strategies. We find that against a potential availability of 585 rupees per capita in 2040, we will need in 2040 about 400 rupees per capita. Now, this needs policy change. Currently, if you ask me, what is the government expenditure per capita, right, on healthcare? On average, the government is spending, let's say, about 2,000, 2,500 rupees per capita, right? You would expect if the disease burden was 10%, government should be spending 250 rupees per capita on mental health. The current number is 7 rupees per capita. In fact, bulk of it goes to institutions like NIMHATS. It's not even available for the broader community. The famous district mental health program, I think the last year allocation was 130 crores. Nothing, right? So there's clearly work to be done by people like me and others to tell the government, no, this allocation is not enough. We need to do more. But I have other papers that, because I'm an economist, that's kind of expected of me in the Lancet that came out last year on, can the country afford universal health coverage? Because one of the questions people ask is, okay, you give me 400 rupees for this, but where's the money for diabetes, hypertension, cancer? I argue that actually money is not our problem. We are saying it's a problem in order to get away from dealing with the other problems. What are the real problems? But roughly speaking, at 2,000 rupees per capita, I think our paper suggests that we can deliver universal health coverage. 12 Indian states are already spending more money. Government is already spending more money than that. Now, by 2030, we think even UP Bihar, with some support, should be able to get there, which means I can find the 400 rupees. We make some other broader recommendations about what is needed. I won't spend time on that just now. And we conclude that with these interventions, India can aspire, near zero, really take sharp. Now, it needs more work by people. We are working hard. One of the centers that I'm trying to set up, and we are making some progress. I wouldn't yet say good progress, but some progress is the Center for Public Mental Health, which if you look worldwide, there are such centers. Some of them run by the government, some of them run by the private sector. These are places where if you are an NGO, if you're a government that says, I really want to deal with substance abuse in my college, I give you a list of evidence-backed interventions. There is a program, for example, called the Blueprints program, which gives you one tick, or no ticks if the program is experimental, one tick if it's been tried in one place, 2 ticks means close your eyes and implement. It's been sufficiently studied, sufficiently documented. India doesn't have such a place. If you're anybody that wants to do some stuff, you don't know where to go. We think a center like this one can become such a repository that one can actually use to build this out. I know we have limited time, so I'll stop here. But there are many interventions, that one could imagine that I speak about. The presentation copy is with you, so I will request sir to share it with you. You'll get a sense of what these numbers are. The paper is there. It has a 60-page appendix. So, but I know you're all used to reading much bigger things, so it won't be a problem for you. But most other audiences say, oh my God, you're never going to go to the appendix. So, there are a number of mechanisms that we talk about. the anti-bullying program, the home-based, psychological stimulation, the good behavior game that I mentioned to you, simple, straightforward game. We are starting to roll it out in Assam now. 15 government schools have already started to roll it out. Assam government has said to us that if it works well, we will think about. Meghalaya government has already put this in their policy to roll this out. We need 1 or 2 places to get comfortable with it before we blitz it out to all the governments. Some private school systems have told us they want to roll it out in their school systems. Many individuals are approaching us to say, I really like this program. Can I champion this and build an NGO myself to build something out? Well, why not? At least for the phase 1 programs, we feel quite confident that the evidence base, both for no harm and for positive impact, is quite strong. I'll stop here, but I'm keen to spend the rest of the time just chatting with you and seeing what you think.
Thank you for a very engaging talk. And it was really giving a complete outline on how the policy should go towards when you want. It's open for questions. Yes.
Thank you for a very nice talk. I want to go back to the point that you mentioned about universal health care for the country. So what is the kind of model that you envisage for that, and how much will it cost? We have villages, we have cities.
I'm happy to talk about it. It's just, let me give you a quick sense of it because I want to spend time more on this paper. We now know that a lot of basic diseases that we understand can be dealt with by protocol. We do not need medical judgment to play. And then I was thinking to myself, okay, that's a good insight, but where have people done something about it? I discovered, for example, Alaska, in a highly litigious US medical system, they implemented the entire version of this approach 40 years ago. And now are able to offer universal health coverage in every single village of theirs, at least at the comprehensive care level. Mental health, there are gaps. Dental health, there is gaps. But certainly in the basic health care, they're able to offer it. What is the core idea? Core idea is to evolve the community health worker into a much more advanced bionic version, able to do a lot more, not simply the ASHA doing the basic messaging, doing a lot more, driven a lot more by protocol. Iran, for example, has built this model in its villages. It's called the Behbaz model, in which it has been able to find that it can reduce NCD burden, it can reduce mental health burden, somewhat taking a pharmacological approach because you can't follow the counseling kind of approach towards everything, and shown very, very good results at a nationwide level. No reason why we can't replicate something like this in the country. Costs of that become quite low. The other big insight in the paper is that while we talk about it, somehow I had not seen it translate into official numbers. Just to give you a number, a nurse, you can go to a website called insight.com and look at nursing salaries around the world. Anywhere you want, you'll see a nurse advertised. We compared identical job descriptions of nurses across the world. Roughly speaking, the Indian nurse costs me about 200,000 rupees per year. The same nurse costs me 80,000 US. I get an exchange rate of 2.5 rupees. Not 20 rupees of the IMF, not 80 rupees of the nominal, which means, let's take 5 rupees as a number, right? Because there are other things that are a little bit more expensive, right? A 2,000 rupee expenditure in India for healthcare is not $25, but $400. Thailand offered universal health coverage to its entire country at $200. Right? And we did a lot of work on so one of the approaches we took was, let's assume India had no health system. And I built a new one from scratch, bought everything afresh, hired the doctors, built the hospitals, built everything. What would it cost me? I had a very nice co-author who spent a long time. You can imagine how complex a task that was. It has thousands of lines, right? Spreadsheets are very, very large, and Lancet had a statistician that looked at our entire numbers because they were also a bit mystified by the conclusion we were reaching. And we find in the neighborhood of 2,000 rupees, we are able to manage this number per capita. Now it ranges 1,600 rupees at the low end, 2,000, and there's not that much state-to-state variation. Because while Kerala is more expensive, it has adequate supply of nurses. Bihar is less expensive, but you have to pay more to the nurse to come and work there. So in some ways, the numbers broadly, there is variation, but in the second, third order. My belief is therefore money is not the issue. Now, of course, one question that immediately people ask me is, okay, if money is not the issue, then why is it states like Goa, which is spending 5,000 rupees per capita, not able to offer universal health coverage? The argument is design. If you are going to do mental health care with psychiatrists, you're not going to be able to get, it'll cost you a lot more money. You have to think through what you're doing. C-sections, an area that I do a lot of my research on. A lot of developed health systems in India, Tamil Nadu, Telangana, Kerala are doing 60% C-sections in the public sector. Why exactly? And you're going to spend a lot of money doing that. And then you will not have enough money for primary care.
Hi. So I want to know your view about how the artificial intelligence will help in the mental health services. So since we have lack of manpower, particularly in India, so can we use like AI bots for a counseling and then we can decrease our cost?
I think these are promising technologies. We have put them in phase 2 because I'm not yet able to rule out risk of harm. I'm not yet able to rule out, do we really have, for example, if there is suicidal ideation, bot picks it up. What am I going to do next step? Right? If I don't have a good answer to that, I will lose the child. Right? Sometimes the language and the conversation can be triggering. One of the reasons why people don't recommend universal mental health screening in schools, the very question, are you planning to take your own life, can be triggering for somebody who was planning to take their own. Right? So, we haven't really thought through the digital piece. It's very promising. It has a lot of appeal. I would say next step. The argument we're making though is I don't need to go there though. There is stuff I can do without AI, without technology, in the here and now, that is doable. With tech adding a dimension to it, maybe 3-4 years, 10 years from now.
Thanks for a great talk. So I was wondering about your phase 1 and phase 2 of the intervention. So if you think about it as adverse childhood experience and adverse community environment collectively, there are obviously components of each that you could potentially put into phase 1, and then there are segregated. I know it's a tricky question to answer, but as a proportion, you find that it's easier to do phase 1 for the ACEs that are adverse childhood experiences and harder to do it at the level of adverse community environments, because the relationship between those two is so high that if you came in with an intervention for adverse childhood experience, but you have an adverse community environment, you're offsetting it because that hasn't been fixed. So I was wondering, when you divide these, how are you thinking about them phase 1?
Yeah. So one good thing, Dr. Vaidya, is we didn't go about it like you are going about it like a scientist. We went about it like economists. So we started the other way. We said, where is there evidence of impact? Right? So for example, we find National Rural Employment Guarantee Scheme eliminates the economic uncertainty that a child is likely to face. It's an important ACE. I don't know if I'm going to go to bed hungry tonight. Right? That uncertainty now goes away. And interestingly, I have a new paper on digital public infrastructure. There are the modern versions of the NREGS, which are not government, but will have the same effect in urban areas. Can you guess what that is? Swiggy. Right? I can be a young person getting off the train. I have no training. I don't need to beg. I won't become a millionaire, but I will not sleep on the pavement. My children will have food because there is Swiggy hires, I think, a person every minute. And I tried to log in myself to say, okay, I have no skills. I've just got down from the train in Bangalore from a high-speed train from Patna. What can I do? They'll give me a cycle also. to get going. Right? So there is an opportunity for us at a systemic level.
Because that's a community effect straight out, but with huge impact on both community and adverse childhood.
Yeah. Now, you might say, what about prevention of the adverse childhood experience? There housing becomes quite important. There you can't just deal with Swiggy. You then have to deal with all kinds of other issues. That goes into phase 2. Because that intervention, because we went with what have people done that has produced the impact on depression, at least the study one we quoted, 12% drop. Directly, they didn't even look at the second generation effect. They just looked at direct impact on depression of the family, of the individuals. Enormous impact. Right? Now, imagine an environment like ours, in which what used to be the case for McDonald's in the US, you could always get a job flipping burgers. You didn't need to starve, you didn't need to beg. So the only people who were on the streets were either schizophrenics or some other issue was there. They needed care. They were in the recovery phase. Right? Because everybody could get a job at a McDonald's or at a Walmart or at something else. We don't have that equivalent, but we have the Swiggies, we have the Zomatos. And then of course you want more skill, more money, you go to the urban company type roles. And these have become really large. These are not any longer tiny, cute experiments in one corner. And I'm told in the second tier, third tier cities, they have enjoyed respect as well as a job. In Bombay, Bangalore, you might say, woo. Not in a smaller town. Yeah, yes.
You mentioned about the C-section deliveries, and we know that the first 1,000 days are very important in the shaping the outcome. That encompasses the pregnancy as well as first 2 years, right? So as I see, there is increase IVF or artificial insemination going on throughout the world. So what are your views on how that impacts the mental health or the community burden, and whether that is there any research with respect to mental health of the child?
So the IVF bit I have not seen, I must say. That is something, the in vitro fertilization, I have not seen. Currently, I have treated that more as a emerging issue that we need to worry about. I am right now in my research on C-sections much more worried about low-risk women, prima gravida, first child, what we call Robson 1. Baby is in the right position, cephalic position. Why is she given a C-section? That's the question I'm worried about. And it turns out that's a lot of C-sections that are there. Ideally, that number should be 0 or near 0. It is closer to 50-60%. There are a number of mechanisms that appear to have a link. The diabetes link, the 45% higher risk of diabetes of this child. I'm told it has some impact on attachment as well between the mother and the child. Now, it of course depends on how soon you start breastfeeding, but typically the C-section mother, the C-section baby are kept apart. And after today's discussion, I'm wondering whether that critical separation, has long-lasting effects on the mother. There is some link with postpartum depression. For example, the mother is less willing to accept the child. Now, what are the mechanisms? I don't fully understand. My interest as a public health person, unfortunately, I don't have the depth of understanding either as a doctor or as a biologist, is much more, why are they doing it? So my research is what is going on in the public sector. Why is a doctor in Mehboob Nagar doing 60-70% C-sections? They don't make any more money. There's no convenience motive. In a private sector job, my obstetrician has to deliver my baby. If I'm going to get a baby at 2 in the morning, well, she has to wake up and come at 2 in the morning. That's not true in the public sector. Public sector is a shift. I went home, I sleep happily, the next person does it, right? That's the idea. So that's what I'm interested in, because what I want to do is to go back to the government with a plan of action to say, what can I do in the public sector? What is the impact likely to be on the private sector? At least if I can solve my public sector problem as a regulator, I then become more powerful. Today, if I go as a regulator to the private sector, they say, well, get your house in order first. You're telling me, but what about you? You lose credibility. So that's what I'm interested in. And I'm finding some very promising hypotheses coming from a variety of situations where There are deeper changes. Again, phase 1, phase 2. Phase 2, there are changes. Phase 1, there are changes. And then, of course, some of the research that you all shared with me, it's really quite eye-opening. I had not even gone in that direction to think about where the harm is coming from. And you want to be a little bit careful though also, because there are some mothers that will need C-sections. You don't want to frighten the hell out of them, right? You want to be sure that you are being sensitive about this issue, because again, India is such a diverse country. Bastar has a 1% C-section rate. It's so low, and it's most likely fully electives, which means a woman that needed a C-section, I like to say Nefertiti had it 2000 years ago. We can't give it in the 21st century to a woman in Chhattisgarh. Right? So you have to be again a bit more careful about how we articulate that.
So I'm just thinking on the fly now. So these days you have a lot more competition in the job market, in at schools, at colleges, etc., etc. So which part of whatever you said today is going to work with respect to mental health issues that crop up purely because of stress that is accumulated, as a result of studies, or when you're applying for jobs and stuff like that? How is that? How are we going to tackle that? Because that's a hugely increasing problem.
And it's not just that, right? We're going to build cities, we're going to migrate people, families are going to get, when I went to IIM Ahmedabad, there was reports of suicide there. I got a call from my family in Yavatmal to ask me if I had failed yet. I was curious, why are they asking me this strange question? Here I am struggling to survive. They were worried that I would do something silly. They wanted to let me know that the family is very proud of me. And there is no reason I should be doing anything silly if I didn't wake out. You come back. And I tell you honestly, it gave me a lot of comfort. It gave me a lot of sense of, it's okay, this universe I didn't do well, but there's a larger universe out there. But a lot of people don't have that access to that universe anymore. Now you are make it or break it on your own. So there are many stressors. We think resilience is an important component of it. If this good behavior game and many of these issues you're able to deal with, much more clearly, there are some important issues there. There's an opportunity for reduction as well. It's not as if all stresses are good. If a child is getting bullied in school by the teacher sometimes, by another student for some time, that stress has to be eliminated from all schools. Right? There's no way we think, and we know how to do it. There's no reason why we should not get rid of ragging, get rid of some of these issues. And the good thing is there are effective programs that people have developed as to how to go about doing it. But then, of course, stress will be there. We have another paper, which is not quite here, on workplace mental health, where we argue that there are many drivers that companies, colleges, schools can deal with. Just to give you two of them. One is what we call socially constructed perfectionism. This movies like 12th Fail and all promote this idea that either you get in or you're a chaiwala. Right? It's not the real world. The real world is there are many choices that are available to you. Right? So it's not one success factor, but somehow our culture promotes this idea. Right? Second is one path. One goal, one path. We want schools and colleges to actively work against both these ones, because these are dysfunctional stresses. We are not a college that I was speaking to told me, don't tell us to reduce stress. We need results. Otherwise, parents will stop sending their kids. I told him, sir, I'm not talking about that. I'm talking about a way in which you moderate that stress. Stress is good. Without stress, there's no growth, there's no development. But stress produces great Olympic athletes that go on to be wonderful ambassadors in the world. Stress produces Olympic athletes that go on to hurt themselves. Right? How can we create that environment? So those are all issues that are still ahead of us. A lot of these programs work at population level, strengthen that capacity, allow us to build recovery much more quickly. And now rest of our work, in fact, my co-author's work, now we are doing a work on suicidal ideation, for example, trying to understand what's going on with suicidal. Suicide itself is a complicated area. There's a volitional element to it. After ideation, that has its own kind of confusing pathway. But ideation is something numbers are large, and something we can actually work.
Hi. So one of the points you had mentioned is about how families contribute to the early well-being of the child. I was wondering that when it comes to suppose Bihar, we have joint families in, still in rural parts of India. On the other hand, we have the US where such things are not that prevalent. So do you think the inherent social structure itself is, could impact the well-being of a human being? So if there's a migrant worker who is leaving a joint family coming from rural Bihar to maybe Mumbai, okay, there can be some impact on the mental health well-being of the kids. But will that hold true in a place like US also?
So my understanding, because a lot of our intervention evidence is not Indian, it's all over the world, right? So one could legitimately ask the question, this evidence is from elsewhere, will it work in India? My response to most people is there's no one India. Can Bihar learn from Kerala? I don't think so. Bihar can learn from Bangladesh. Kerala can learn not from Bihar, but from Brazil, because those are systems that are more closer to each other. So there is that one issue, right? The second issue is, what about the, every society is going through its own transition. Have we built the capacity? For example, my son was in a school in the US, university in the US. The amount of counselor support they had on ground, I cannot even imagine in India. So while the family is fracturing, their environment is a tough environment. I lived with my brother until, I was so old, but I felt no shame. My brother, in fact, refused to let me spend my money. He said, no, I will give you the stipend. Whatever you're earning, you keep for yourself, right? You go for a movie or something, right? Anyway, that was what the public sector was paying me, just enough for that. But, it was not considered odd. In the US, at the age of 18, you're cut off. But that society has evolved its own responses. Of course, they have a lot of mental illness. I'm not telling you, but relative to us, relative to elsewhere, I don't know. The numbers might not that bad. Europeans, they have a very different environment. Unfortunately for us, and I see this a lot in diabetes, you see a lot in other areas where our health systems have not evolved, but our lifestyles have changed. We live like Americans, eat like Americans, but don't have a healthcare system that is comparable. Colon cancer, their colonoscopy rates are 90s, in the 90%. What is our colonoscopy rate? It's so small that you have to look with a microscope to see what that number is. We're just not doing the colonoscopies. We don't have the facilities, we don't have the ability to do it, we don't have a public health messaging to do it.
I just had one more question. It's very fundamental in the sense that if suppose a government is spending in the education sector, then it sees an incentive that, okay, if you are investing in a technical institution, you will create engineers, they will drive the growth of the country. Innovation drives the growth. But what is the incentive that a government sees in improving the healthcare in general? I mean, if the government isn't spending on healthcare, then the burden shouldn't go up either. You understand? So
it's a deeper question on what is the objective of the government. What does the government want to do? Why do we need the government at all?
Is it a welfare state?
One could argue we don't need the government at all. If all that the government is going to invest in growth,
right,
I can do it myself. Right. You give me my money, remove taxes. And many countries around the world like small government for this reason. Where is government supposed to intervene? Where markets are not able to solve problems on their own. That is where a welfare maximizing government will go. But you might say, okay, we have a confused government. We're not sure whether it's welfare maximizing, growth maximizing, what is it doing? The number one reason for descent into poverty, health expenses. You want to grow? Well, you can't grow until you reduce poverty. If you don't have healthcare access, people will go. Some states are showing diabetes burden of 30%. What does that diabetes burden mean? Untreated, undiagnosed. In 5 years, epidemic of amputations. Every home an amputee. Now where is your growth gone? Right? Some people told me there was a women's commission on women's health. They couldn't make an argument as to why investing in women's health matters for growth. The point I made, I was a reviewer for that, is that Indian female labor is unpaid labor at home. That's terrible. What is the attractive thing about it? It's not easily substitutable. Right? If a woman of the home dies or falls sick, what happens to the home? Fully breaks apart. Right? In fact, you can explain GDP differences between countries on the basis of maternal mortality alone. Just those differentials. Because every family now is focused on looking after each other when this poor woman was doing it all. So there is a growth connection. Even if you said, forget welfare, all I'm interested in is growth. There is a direct growth connection. And mental health. I've met families with schizophrenia. If you know of any families with severe mental illness, the entire family's life is around that individual. Where is their productive life? Where is their ability to grow and to contribute to the economy? So clearly there is a lot of value.
Just a quick question from Zoom.
Yes, okay. Thank you. Sorry, I should be.
Basically, talking about the work-related stresses and the developmental health issues which comes from the stressing work environment. You covered some about maybe armed forces and all, but it's not in general, but not armed forces, but in general work stresses and things and all. So is there any policy guidelines or something which can be done?
I think the issue is we still don't fully understand.
That's the question.
Yeah, no, I think it's a great question. We don't fully understand the mechanisms that are, there is this general view, stress is not good. That, poor girl who passed away in Pune because she was under enormous stress. We don't subscribe to that view. Our view is, I'll give you an example. My background, I work in public health now, but originally I am a derivatives trader. My background is in stochastic calculus and options pricing and such likes. And I ran for the longest time the ICICI Treasury. Right? Now it's a very high stress environment. We are roughly at 10,000 crores a day of trading volume. That was many years ago. I'm sure it's much more now. And you could lose or gain large amounts of money with small errors. Now imagine a youngster sitting on the table, with a position, right? And I had built the whole room of glass so that sitting in my cabin, I could see who's turning pink, right? Because I could go and understand what's going on. Some people thrived in that environment. They would come in buzzing, they would leave buzzing, even if they had lost money that day, right? Some people would just shrivel in that environment. They couldn't handle this boom, tick by tick, one movement, boom, 200 crores gone. Another movement, boom, 200 crores gone. After a while, you start to go crazy with that. Fitment of the person. Some people were good at analytics. Some people were good to make the computer code, to come up with the models. They were not good to hold positions. Some people were great to hold positions. They were not good at it. And part of my job was to find the right fit. That fit, stress I have not taken away. The market is still stressful. But if I fit them well, both thrive. The analytical person thrives, the trader thrives. Now, my sense, there are some of these, so goodness of fit is a moderator we want to test. And companies, have to, recruitment is not the end of recruitment. You have to spend another month or 2 months understanding your staff to see what it is that they are doing. And don't forget the regular stressors of the outside world, bullying, sexual harassment. These are very much in the workplace. Companies have to make every effort they can, not just for POXO and other things, just to make sure they have a vibrant environment to eliminate these stresses. There's no way to work around those stresses. So we hope to have more papers, more empirical work on this, but that's our model. We have a workplace mental health model that we've published, which we hope to now test much more carefully.
Thank you very much for the answers. I think, please join me again in thanking Professor for a fantastic talk. And I hope that this has been a very useful for all of that. As he mentioned, this presentation will also be available on asset web pages, as well as the talk and the recording in YouTube. So my request is please spread it as much as you can.
And the paper is also available, you can.
Paper is also available on the same site.
That as well.
Thank you very much. Thank you very much.
Thank you. Thank you.
Please do join for the team.
Thank you very much, sir.
It was a pleasure.
Thank you.
Please do have a team.
Okay. May I leave this here then? Yeah, let me get rid of this thing. The whole world is hearing me.